The following podcast is part of a certified educational activity titled Unlocking the Power of Modern Therapeutic Regimens for Prostate Cancer. Experts put the pressure on key evidence and real-world strategies to optimize patient care. Access the entire activity and complete the post-test at peerview.com/YWU860. Downloadable slides and practice aids are also available.
Good evening, everybody. Thank you for being here and for making it after a long day here at ASCO. Big traffic, rain, everything, jet lag. So enjoy. You'll have dinner, obviously. We'll speak about science and medicine, but it's really also time to relax, and we did our best to do that. I'll come back to that in a minute. I'm Karim Fizazi, medical oncologist from France. I'm delighted to be here with you guys. And I will introduce all the three superstars just next to me. But first, we're going to speak about prostate cancer. It's been a very evolving situation, which is great for patients, but it's getting, of course, more complex for us as doctors. That, again, it's a good thing to have. And we're going to try to help you with this regards. So, I already introduced myself, but we have Dr. Pedro Barata here in the center, Dr. Kim Shi from Canada to the right-hand side, or this for me, for you is on the left, and we have Dr. Alicia Morgans here just next to me. Thank you very much to the three of you for attending. So basically, we have several goals. Try to, improve your understanding about what we're doing right now for patients with prostate cancer, specifically for men with advanced disease. Try also to equip you with strategies for incorporating those new treatments, and also try to provide guidance to try to mitigate the side effects we are unfortunately providing to some patients. And also educate patients because we should really work as a team with patients. That's so obvious. Okay, I said that it's been a long day. We've been working hard already. So it's time to relax, at least for you guys, and I guess for myself as well. But not for these three people, sitting just next to me, because they will have to work. And it's going to be a contest between the three of them. We'll have a number of different questions, of course, silly questions sometimes. And they will have the opportunity to provide, hopefully, the good answer. And they will be rewarded with points if they do so. But, of course, if they provide a bad answer, it's going to be a negative points. So, hopefully, this will be fun. And let's start. When it becomes green, you can answer. So whenever you like. What? All right. Wow. What year was the first ASCO annual meeting held? What is your answer, Kim?
I have no idea. I'm just guessing.
All right.
1974.
I'm not sure. Oh. All right.
I want to say 88.
1988. Oh. Okay.
Okay. Wait, before Alicia answers, she revealed to me she's never won a competition.
I'm living for her. So my thought process right now is, do I just take a pass and then
No.
still winning? Because if I'm gonna
50% chance. Go ahead.
Oh, go for it.
Oh, great. Which ones were chosen?
So you have. Oh, okay.
I'm gonna take a pass and pass over to Karim, because at least then I'm not negative.
All right.
I have ended these games negative before, everyone, so I'm just not a good buzzer.
All right. ASCO is old. 64 was the right answer.
Oh, wow.
And I would not have gotten that.
Wow.
So that was a good decision.
Me neither.
Yeah, I know that from a friend who was born in 64, so he's always proud, every time it comes to ASCO, he's like, well, that's for me.
That is for him, yes.
Yes. All right, so minus 100.
I'm winning.
He's winning. All right.
For now.
Okay, you have another chance. what would the hazard ratio for metastasis-free survival in the phase 3 EMBARK trial, demonstrating the benefit of combination therapy over castration alone for patients with non-metastatic hormone-sensitive disease?
Is it 0.42?
Amazing. Good job.
What did you say, Kim, by the way? She's never winning?
She's never won this.
Oh, okay, in the past.
Not bad, yeah, not the present.
I paid both of them actually at the beginning.
All right.
So.
Okay, guys, you need to do something about that, okay? You'll have opportunities. All right, but because she's winning now, she's also allowed it to speak and provide the first presentation.
Thank you, everybody, for being here and for being patient with our game, which is actually very stressful for the three of us up here, but hopefully entertaining for all of you. So I have the opportunity to really talk about localized prostate cancer and biochemical recurrence, which has been an area where we've had quite a bit of development over the last few years. I think as we consider this space, first, we have to kind of think about who are these patients? How do we define high-risk localized disease and locally advanced prostate cancer? And you can see here in this figure that the majority of patients, of course, are diagnosed with localized disease, a lot of that being low and intermediate risk, but some patients with high-risk disease. And importantly, as we're treating those patients with definitive and we hope curative therapy, we recognize that 20 to 40% of those patients are actually going to develop recurrent disease despite their radiation or their prostatectomy. So that biochemical recurrent population actually is quite a significant one. And these patients do have the risk, certainly, of developing metastatic disease and dying of prostate cancer. We can see on the right-hand side that there are some high-risk features that are associated with higher risks of prostate cancer-specific mortality, things like a higher PSA, higher Gleason scores, a T3 or larger tumor, or high-risk disease overall. And so it really identifying these patients who are at highest risk of dying from prostate cancer is critical as we think about initiating treatment in a patient population that by definition does not have evidence of metastatic disease in the biochemical recurrent state and is generally asymptomatic except for the anxiety and pressure that they feel from having that recurrence. So as I said, 20 to 50% of patients are going to have this recurrent disease within 10 years of their definitive therapy. And prior to some of the more recent trials, there have not been real studies demonstrating level 1 evidence of benefit for improving disease control in this state for the hormone-sensitive biochemical recurrent patient population. They are, particularly with those high-risk features, at increased risk of that prostate cancer-specific mortality. And so there are certain situations that we need to consider. Certainly we'll get to the EMBARK data, which is some of the largest registration trial phase 3 study information that we have for the non-metastatic hormone-sensitive setting. But we also know that for those people who have high-risk localized or locally advanced disease, we also have some opportunity to intensify our systemic therapy and hopefully gain better disease control, prolong time to metastasis, and improve overall survival. So the STAMPEDE trial has done multiple arms. We're all aware this is a platform trial with a single control arm and then multiple arms looking at various interventions. And one of these comparisons was really a platform study looking at, or part of the platform study, looking at patients who were receiving abiraterone and prednisolone with or without enzalutamide in that non-metastatic high-risk patient population setting. These patients had to have multiple risk factors to be included in this analysis. They had to have either pelvic lymph nodes by conventional imaging, or they had to have 2 out of 3 of T3 disease, a PSA over 40, or Gleason 8 or greater. And so in this patient population, Gerda Tard presented, and the STAMPEDE trial team members showed us that if we use definitive radiation with ADT and abiraterone for 2 years, we can actually prolong metastasis-free survival and overall survival as compared to that radiation and ADT for 2 years. So adding abiraterone, adding an ARPI is an intensified way that we can improve disease control outcomes for this patient population. And this has become standard of care for a high-risk, locally advanced or high-risk localized population. There are multiple phase 3 trials that are ongoing, trying to understand how to better treat our patients with high-risk localized disease or locally advanced disease. And we can see there are a number listed here. Some of these are using radiation therapy like Enza-Rad or in DASL-HiCaP. There are others that are using chemotherapy like PEACE-2, which is a study that Karim is working with in the European group, the PEACE group. We could see others that are really just intensifying around ADT, and the Proteus trial, for example, is using a neoadjuvant or perioperative approach to intensified systemic therapy to try to see if we can cure more patients in this disease setting. So let's just run through several of these. I think these are going to be studies that will read out in the next few years that will continue to change our landscape. And just to reflect, I think it's been pretty incredible the way that the AR pathway inhibitors have moved from the very advanced disease setting all the way back through various disease settings, and in this case, in a neoadjuvant setting, to really hopefully continue to provide benefit. And in every setting that we've investigated, they seem to provide benefit. So I think we're all hopeful. So the Proteus trial is a study looking at localized or locally advanced high-risk and very high-risk patients with prostate cancer. I participated in this study and continue to have patients on this study at my center. They are very high risk, and they are specifically identified to be such. They get a neoadjuvant ADT and apalutamide versus ADT lead-in. Then all patients get a radical prostatectomy. And then there's a 6-month apalutamide ADT or placebo and ADT post-radical prostatectomy period of exposure. There's also one group that's not listed on here, but that was added later that is goes right to prostatectomy as well. So just another arm here. But eventually, ultimately, these patients are being followed for a pathologic complete response endpoint. So this is being done on the prostatectomy specimens to look to see if that neoadjuvant lead-in can cause path CRs, which we see in other solid tumors to be very closely associated with disease control, and also metastasis-free survival. So this, I think, is fully enrolled, and we're really excited to see where this goes. The ATLAS trial is looking at apalutamide and ADT in high-risk localized and locally advanced disease as well. And patients here are getting radiation. And so again, using apalutamide in this intensified strategy with radiation to see if there can be an improvement in these outcomes. This is a long-term ADT strategy. Here we have DASL-HiCaP, which is a little bit more of a complicated patient population, but includes that very high-risk localized disease patient group who have high-risk features, and they have PSA persistence after their radical prostatectomy, or they're getting radiation up front. Again, it's a little bit more of a complicated sort of heterogeneous group, but in any event, they are being randomized to darolutamide and ADT versus placebo here and being treated for 96 weeks. Again, looking at metastasis-free survival, which is a common endpoint in this early disease setting. EMBARK is a study that we have heard about actually at length. We continue to hear about it at ASCO this year and have had multiple updates. And this is a registration trial that was looking at a high-risk biochemical recurrent population. And these patients came into the study after having definitive therapy and having a rising PSA after that definitive therapy. They had a PSA doubling time of less than or equal to 9 months and no metastatic disease on conventional CTs and MRIs or bone scans, and they had to have a testosterone over 150 on entry. Patients were randomized in a really interesting fashion to enzalutamide and leuprolide versus leuprolide alone, leuprolide being the commonly used standard, or an ADT GnRH agonist backbone being the standard here. And then there was also an enzalutamide alone single agent AR antagonist arm, which again is a little provocative, I think, as we consider that this study was developed 9 years ago or so, quite a long time ago. Patients were treated to week 37, and if they had an undetectable at the time, a PSA of less than 0.2, they could stop their treatment, their systemic treatment, and continue to be monitored until their PSA rose. For those patients who did not achieve that low PSA, they just remained on treatment. And here we see that primary endpoint is the metastasis-free survival by BICR. And the secondary endpoints, of course, are things that we're quite used to: time to PSA progression, overall survival, quality of life, et cetera. And here we can see the primary endpoint of metastasis-free survival with the enzalutamide and GnRH agonist or leuprolide combination versus leuprolide alone. And what I think is really fascinating here is that there hadn't been actually solid evidence for use of a GnRH agonist or antagonist ADT alone strategy to really change the trajectory of disease and biochemical recurrence, hormone-sensitive biochemical recurrence before, but that had been our standard of care, that intermittent ADT backbone. This very clearly beat that, which is impressive, demonstrating that an intensified systemic therapy combination could prolong metastasis-free survival here. Here we see the time to PSA progression, also demonstrating enzalutamide and ADT combination versus that leuprolide ADT backbone alone, showing a hazard ratio here of 0.07, highly statistically significant in terms of PSA progression. And here we have the enzalutamide monotherapy for metastasis-free survival versus leuprolide alone. Provocative that this AR antagonist also beat our GnRH agonist as a single agent. And this has led to the development of additional therapeutic trials that are looking at AR antagonists as single agents to see if we might be able to get rid of these GnRH agonists or antagonists as backbones. And here we can see the hazard ratio of 0.77. And actually, enzalutamide monotherapy is now an approved option in this disease state as well. The safety profile is really interesting, demonstrating that enzalutamide combination and enzalutamide monotherapy have slightly different they have slightly different adverse event profiles. So we can see that generally they're relatively well tolerated, as we expect from hormonal agents. But we do have to keep in mind with enzalutamide monotherapy, because we do have an elevation of testosterone, increased peripheral aromatization of testosterone to estrogens. You can actually get gynecomastia and painful gynecomastia as a complication of single agent treatment here, something for us to be aware of with our patients. We also had some data on the quality of life for enzalutamide monotherapy and for ADT or leuprolide monotherapy among those patients who had treatment suspension. And we could see that there was a favorable biochemical response in that setting, with enzalutamide monotherapy having 86% of patients actually getting to the point of being able to suspend their treatment at week 37 versus 67% of patients who were treated with leuprolide alone. And the quality of life data was actually, more quality of life data was presented here at this ASCO. We have a slide on that in just a minute or so, but really achieving a higher rate of PSA suppression. We also have heard over the last couple of years the phase 3 PRESTO data. This is high-risk biochemical recurrent patient population as well. These patients had to have a biochemical recurrence with a PSA of 0.5 or greater, with a doubling time of less than 9 months and no metastases on conventional imaging. And they were randomized to treatment with an LHRH analog plus apalutamide and abiraterone versus an ADT analog plus apalutamide versus that GnRH analog on its own. And we can see, we actually do not show you those data, but at the bottom we can see that at that first interim analysis, PFS was actually prolonged when you use that intensified strategy versus the ADT backbone alone. So a very similar message here with PFS by PSA PFS. ASCO updates showed us that the EMBARK quality of life data really suggests that in that treatment suspension period, as expected, we could have improvements in health-related quality of life, though everyone's quality of life, regardless of arm, does decline over time. I guess that's just being alive at some point. We all decline over time, but it was interesting to characterize that in that population. And the PRESTO health-related quality of life, also reported at ASCO, showed that we really are able to increase our systemic therapy, and we can intensify there without compromising on quality of life. ARISTEP is a really interesting phase 3 trial that I'm fortunate to participate in. I know Kareem is participating as well. And this is a high-risk biochemical recurrent population that has PSMA PET positive identified lesions. And all patients are offered the opportunity to get metastasis-directed therapy to those lesions and are also randomized to receive systemic therapy, ADT alone, or ADT and darolutamide for 24 months. And the goal here is to see if we can prolong metastasis-free survival by PSMA PET. This is a novel endpoint. PSMA PET has not been used in this setting before. We will see. I'm hopeful that we'll be able to shift the curve with this intensified strategy as well. And there was some updated data from Aramis here also demonstrating that if you can get to that really low PSA, less than 0.2, we can actually have a lower risk of recurrence radiographic progression over time in that population as well. And finally, I would just wrap up by saying that prostate cancer advocacy group, ZERO, has really a lot of resources for patients to both get financial support, to get counseling, to get mentorship, to have peer group support. And so this is just an illustration of some of their resources for us to be aware of as we leave, and you will be able to download these resources over time. So thank you.
Thank you very much, Alicia, and right on time. Excellent. How do we balance intensification in localized disease or biochemical recurrences with adverse events? Do we need to define a very high-risk subgroup, or are we quite set?
Yeah. So it's a wonderful question, and actually a question that we struggle with each patient, I think, in clinic. So the clinical trials often try to define the high-risk subgroup to say this is the group that in general as a field we think we should kind of push forward with intensification. But I think importantly, in the US at least, the labels do not restrict to high-risk subgroups, which gives us as clinicians latitude and patients as patients latitude to engage in those intensified strategies if they think that it's worth it or not. These are nuanced discussions with patients, and one of the things that I always talk about is that if you engage in an intensified strategy and it is too much for you, and everyone says, oh, what do you mean? Well, sometimes the side effects are too much for certain patients. They can stop. This is not surgery. This is not, long-lasting radiation effects, so they can stop. And I think knowing that these things can be reversible, certainly if stopped in short order is best, is important. But I think that it is up to each individual patient, and these are these can be ongoing conversations with patients over time.
Maybe another question this time from myself. So I think one of the most striking results we saw, say 3 years ago from Stampede, was really the aberration hypothesis being tested in very high-risk localized disease, with not only metastasis-free survival being improved, but also overall survival, really the first time in, 25 years in localized disease. So I think this is a game changer, but still, because the drug is generic, it's not formally approved. So when do you think we may see data with the other 3 drugs, the AR pathway inhibitors? We're waiting for this data, and you nicely showed the design of the trials. Should we expect them soon or not? What do you think?
I think that multiple trials are actually fully enrolled, and these are event-based analyses, and so we have to wait for events. And when we're talking about localized disease, these events can take some time, especially if they have really effective therapies on board. So as I mentioned with Proteus, which is one of the studies that I've participated in, the study team has actually selected an extremely high-risk patient population, and that is one strategy we as investigators have to try to make sure that the trials have events at a rate that is fast enough to answer the question. So I think they've all been designed in a similar way, but we as clinicians and as investigators ourselves, at least I find myself, always kind of straddling the line between saying, I want that data to come immediately, but also I recognize the faster the data comes, the faster the events are happening, the faster the patients who are on those trials are actually having complications and events. So I expect that it will come as it comes, and I hope that it is, at the pace that it comes. But I do think within the next couple of years we'll have some of that data.
Okay, let's move on. Next question. Sure. What was the primary endpoint of the phase 3 PEACE-1 trial? What is that? PEACE-1, I don't know. Was that OS, RPFS, RPFS and OS, or MFS? Any idea?
Okay. It's your turn.
It's my turn?
Yes.
So, what
is it RPFS?
I don't think so.
Oh, God. I had a
Anyone
different
else
answer
want
that I
to
was
try?
going to choose. You can't discuss with each other. You have to.
I know. I'll vote on your section.
All right.
Oh my gosh.
Well, don't worry, Alicia. If we work together, it's going to be minus 200 now.
OS.
No, sir.
I knew it. I knew
It's
which
both.
one it was.
I think it's both.
Then you get it, Pedro. You get it.
Well, I shouldn't say it because it's my section. No, you're not.
Yeah, So you're trying something else?
Pedro, you can answer.
Oh, well, I'm sorry. What happened?
You buzzed in. Answer.
Yeah, I did. Oh, I thought I said both, but I think.
Oh, both. Sorry.
Yeah,
So
yeah.
RPFS and OS. Should I
think
say
so.
that? Okay. I think that's the right answer, indeed.
Yay, Pedro.
Yes, you made it. Okay. Well done.
The lowest scoring PeerView event
God.
ever.
So what was the hazard ratio for overall survival in the initial and I guess final report of the Erasmus trial?
0.68.
0. Point what?
68.
Yes.
Good job.
All right. Okay, more separating now. Very well done, Alicia, again.
Thank you.
All right. So we're going to move to you, Pedro, if you don't mind,
Sure.
with treatment intensification in metastatic hormone-sensitive disease. The floor is yours if you like.
All right, guys. I know who's taking a winner plague tonight. Anyway, so happy to be here. Thank you for the invitation. Fantastic panel. So we're gonna, switch gears a little bit, and or not, right? Because we define metastatic hormone-sensitive disease, thus far we've been doing that based on conventional scans, and all the conversation that and Alicia and all the discussion was also for the most part based on conventional scans. But a lot of actually patients, in the recurrent setting, some of them will have advanced disease also by novel imaging. So we will be talking right now for the next 10 minutes or so, for patients who present with metastatic hormone-sensitive prostate cancer. And this is actually a group of patients that's not exactly the same, right? Volume, we still define volume back from Charted. So remember, 4 more lesions in the bone, back 1 outside the spine and pelvis or visual disease. But the reality is there are different presentations of those patients. There's also a different way to get there. You can get there as you walk in the clinic with newly diagnosed disease, metastatic disease, right? De novo or newly diagnosed metastatic disease, but you cannot, or synchronous disease, but you can also get there after you try to cure the patient, after definitive treatment, and unfortunately disease will come back, and then you detect metastatic disease. And remember, these definitions are, for the most part, are up to now still based on conventional scans in regards to volume. So what's relevant to me is actually when we look at the data regarding the outcomes of those patients, just based on these, volume and timing of metastatic disease, you can really identify 4 groups that clearly have different outcomes, right? And obviously the poorest are the patients who are diagnosed with high volume, newly diagnosed metastatic hormone-sensitive disease. So obviously this has implications for what we did and what we learned in the last, I would say, 9 years or so. So the reality is, everything we explore, and I'll just go briefly a couple of some studies of interest, but, we see that even though we got a number of trials over time in these last 10 years, the reality is, at least in the U.S., we can see that the adoption of, in treatment combination strategies, whether it's for chemo or, RPs, they are pathway inhibitors, right? In this case, you have that representation there here. It's actually not been, adopted universally, at least in the country. And I think that's a lot to go and to do in that particular space. So what do we know? Well, we know that these patients have poor clinical outcomes. We need to do better, and we need to do better by offering them the best treatments out there. We know that despite the data and despite our understanding and how we should treat those patients, still many, many patients are getting suboptimal treatment, castration alone, or with the old combined androgen blockade. I actually remember many years ago with Dr. Fizazi in a panel far from U.S., and we were actually debating, I presented a case of combined androgen blockade. Do not make a mistake. It's different from what we talk today, about the new combination regimens. At that time, we used to call CAB, combined androgen blockade, to bring a first-generation anti-androgen along with castration. We now know that's not enough, right? So now we consider those patients that be getting castration alone, if you will. And finally, of course, we have level 1 data, but despite that, the adoption, as I mentioned before, has been, insufficient. So a way to kind of table this information and this data goes back, from the chemotherapy, fantastic work on both sides of the ocean, with GET2, the Charted, Stampede. We also learned the same with, abiraterone, CYP17 inhibitor, and then we learned the same with the anti-androgens, with apalutamide, enzalutamide, and then more recently combinations of RPs with chemotherapy. And we can see that, the way to summarize this, and you have slightly, we have for all these trials, RPFS, overall survival, we have very important secondary endpoints in terms of efficacy perspective, like things like, time to subsequent therapy, but also very patient-relevant endpoints, right? A lot of these patients had a lot of these trials study quality of life, get things like pain, skeletal-related events, etc. And the way to summarize that quite easily is not only these combination regimens, allow patients to live longer and delay progressions and all the other endpoints of interest, but also they do so by preserving quality of life. In some cases, the patients do better. So when we focus specifically, on RPs, if you will, you think of Titan for apalutamide, you think of Arches and enzalutamide, and perhaps Enzamet, if you will, and then Latitude that Dr. Fizazi led as well. But basically the abiraterone, they also all show an improvement. And by the way, the delta of improvement was quite remarkable, right? We're talking at times deltas can go a year, if you will. So that's definitely an impact, a significant impact in the outcomes of these patients. Now, so again, putting them together, we know that combining ADT with these AR pathway inhibitors definitely prolong clinically meaningful efficacy endpoints. They do that while maintaining quality of life. For a matter of time, I'm not showing all that quality of life data, but actually the investigators in all these studies do a fantastic job, caring about how those patients do while they go on these intensified form of treating those patients. And the next question was, okay, so if I move chemo from the CRPC setting, earlier to hormone sensitive, then that improves outcomes. If I do the same with RPIs in the hormone sensitive setting and I improve outcomes, what about combine all of the above? And so the more recent question has been, what exactly the role for combining all of this in a form of triplet therapy? And we really have two very important pivotal trials. The first of one is part of the PEACE program, led by Dr. Fizazi. This was actually a 2+2 factorial design. Asks two very relevant questions, and this was a continuum as a standard of care change. So the standard of care then became an adoption of a combination at the time with ADT combined with docetaxel. And for here, I think it would be important to highlight the radiographic progression-free survival with abiraterone in addition to the standard of care ADT docetaxel plus minus radiation population. So we're specifically looking into that, and you can really see the outcomes. It's actually quite remarkable. I remember I was in a room and a while, right, when we see a difference of 2 years, right, in regards to our PFS. At the time we saw this, and then we saw the OS later, with the risk reduction of death of about 50%, right, 0.5 for hazard ratio. So fantastic and very remarkable for the triplet was, so this was very, very, very important data when it was presented. And then we got to break down, you have the overall population. Remember, these were patients who were newly diagnosed metastatic disease. And, you see the overall population on the left with a 1 year absolute difference in OS with a risk reduction of about 18%. And then on the right, you have the standard of care of the ADT plus docetaxel, the standard of care defined with a backbone ADT dosi. And you can see actually the delta is more striking with a 25% risk reduction. Then you at the bottom, you can also see that, whether you consider, when you look at the high volume patients, perhaps that difference is more evident, right, with a risk reduction of 28% and, not so or not as much in the low volume population. So again, with this data, I think this data triggered a lot of conversations around who would be the patients, who should be considered for intensification with a triplet, on top of chemotherapy. So the question here is ADT chemo plus minus, abiraterone. And then, of course, following the great work from PEACE-1 is the Arison's data, another very important phase 3 trial. The difference here is we're taking patients with newly diagnosed metastatic disease, so not restricted to newly diagnosed metastatic disease here. And here you can see patients were randomized in a similar fashion in a sense that standard of care ADT docetaxel, plus minus darolutamide in this case against placebo. And OS was the endpoint of interest. And, and as I think all of us know at this point, very positive study, a risk reduction of death of about, 32%, right? And you don't have a median, for survival for the darolutamide, for patients treated with darolutamide, compared to about 4 years or so for patients treated with ADT docetaxel. And so end up, getting approved in this particular setting. So not only the doublets made it through, but also the triplets, made it through. And so we talk about these combination strategies, what are you going to add on top of castration, if you will. Another important aspect, an important question is, okay, since you were able to get patients who get to metastatic disease, either synchronous or metachronically fashion, right? In other words, newly diagnosed disease versus recurrent disease, you can actually, see, on the left, perhaps, we have a 0.71 hazard ratio, the confidence interval solidly below 1, you kind of see the curve separating that quite nicely. And then on the right for recurrent, you have a risk reduction of 39%. In this case, you have the confidence interval a little bit right after 1. I think this is very, important data. I think it's also one of the important questions in the context where we are today, is to ask the question, what happens to these patients once, when they progress. So on that note, I think it's a great opportunity to highlight the post-hoc analysis from Harrison's presenting here, at this ASCO, right? So I would emphasize that for you guys to check it out. It's the abstract 5083, which is really go into this and looks at survival in the context of subsequent therapies. So very important data, I think, being presented at this ASCO. So the other point is, so the big conversation has been around, on one end, synchronous versus metachronous disease. The other conversation has been around the volume, right? And until we get perhaps to the molecular, stage of the conversation, that's really the point, right? So if we identify those 4 groups that I showed you initially, should we treat them differently? So that's where kind of that, when you break down the data by those groups, I think is relevant. So you have top left, high volume, top right, low volume, and then you have high and low risk. I believe the definition is very similar to what was used in Latitude 2 out of 3, and you can see there that, the risk for that is about 30 or so percent across the volume in the risk groups. You can see the medians for the group treated with darolutamide, did not reach median, so it's not reached, right? So that tells you that patients did way longer, we know that the safety profile of this strategy is quite favorable, and so this is really consistent with the intention to treat population. So when you look after the subgroups, you really don't identify a group where clearly there's a lack of benefit, if you will. We can talk perhaps a bit more about the demographics of this particular population that made it into Harrison's, if you will. And so, just, I guess, a highlight, because, now we have available, ADT-ABI, abiraterone, ADT enzalutamide, ADT apalutamide, and then for triplets, ADT docetaxel, abiraterone, ADT docetaxel, darolutamide. And the question is, in regards to the darolutamide, which is, obviously the newer ARPI, you actually have 2 trials that are very relevant, one ex-US and one US. The Aranote, it's actually fully enrolled. The one, it's ex-US. Actually, I believe Arisac is about to complete accrual. Is going to complete accrual, I believe, very soon. And then we'll find out to complement the data, in regard for patients who have not received a backbone of ADT with chemotherapy. This is really the question, regarding how about bringing darolutamide on top of castration. So I think those are, so shout out to those 2 studies, because I think it will help us to perhaps maybe change the landscape one more time. So finally, there's obvious differences, right? When you consider a doublet versus considering a triplet for this patient population. And, when you think of a doublet, you have the question around monitoring. I think this conversation can go very differently when you have a room full of urologists versus a room full of medical oncologists, because it's all relative, right? How we see things, and definitely how we see monitoring, renal function and liver, and also hypokalemias and high blood pressure and the use of steroid that can be perceived in a very different manner by treating providers as well as by patients. And there's of course the pill burden, which I would argue it's on both sides if you're doing doublet, but that is relevant as well. Although there's been an effort from in terms of presenting the pills combined or higher dose in each one. So there's an attempt to actually reduce the amount of pills patients take. And in addition to that, there's also important considerations like cardiovascular aspect or cardio-oncology, cognitive perspective. The bone health is always something that we also bring up, as well as ADT-related adverse events, of course. And then on the triple therapy, if you bring the docetaxel, remember this is a finite number of cycles. You're doing up to 6 cycles, so you have the infusional aspect of this strategy. Of course, you have the toxicity of a chemotherapy, which when you look at the quality of life of those patients is different from patients being on oral therapy. Also the time, the time when this strategy is also different. And finally, we should obviously consider all that was said for the doublet strategies. So that's that's pretty much it. Again, this is an evolving field, and so we're going to have more news. So yeah, thank you for the opportunity. I'm looking forward to the questions.
Thank you very much, Pedro. Keep sending your questions, please. After all those excellent presentations, I'm sure you have some. Let me see if there are some already here. How can you decide between the AR pathway inhibitors in your practice? Safety, duration, importance of PSA response, other things?
That's for me,
I guess.
Great. I don't feel I'm on the spot. So, I think, so if we take the triplet aside, I do think the role for triple therapy, I do select triple therapy for patients who are newly diagnosed high volume disease, for very young patients with high volume disease. Sometimes recurrent and they're very young. I also discussed that, but I think if we were to put them together, I believe there's room for that for about 20% or so. I'm throwing the number out there, but somewhere between 15 and 20% or so. So I saved the triple therapy for that. So most of the conversation will be for the vast majority of the rest of the story. And I was just going to say, of the 100 patients, we see about 15 to 20% where survival is not, of those patients, is not impacted by the metastatic prostate cancer. And that's for many reasons: comorbidities, very sick patients, sometimes patients we meet at the hospital, et cetera. And so the idea is actually to prevent complications from tumor progression. And in those cases, I'm more concerned about treating the symptomatic progression, because I assess what's the life expectancy. So if we take those group aside, I think we're roughly talking about the rest, I guess 60 to 70% of people, depending on how we do the math. And so the question is really, the way I see it at least, you have the CYP17 inhibitor on one end, you have the anti-androgens on another hand. Right now, so if you take the triple aside, so really for the anti-androgens, you have ENZA and APA. They have slightly different safety profiles. I care of things like, the neurocognitive aspect of it, about rash, about the thyroid. If I have to monitor that, that's something I care, on the abiraterone and the drug-drug interactions, of course. And then on the abiraterone, as I care about the long-term steroid use, younger folks. I care about, of course, the diabetes, in addition to the LFTs and the hypokalemia, also the ability to follow up to those questions more or less often. So I don't think, and also the experience. I see people tend to do one thing, which is very interesting, and humans are creatures of habits, and that applies to the providers as well. So it's quite interesting from the feedback I get from the community goes, in general, we know that urologists do more anti-androgens. We know that med-oncs tend to do more CYP17 inhibitors. Historically, that's been the case, and that seems to be the case also in the US. So depending on the situation, I go with one or the other. So I don't have a go-to. I do with triplet, I tend to do more darolutamide instead of abi. With the triplet, in the doublets, I go through this with the patient, and I care about what other medications are on for DDIs.
All right. There are several questions. I'm sorry, I can't take all of them. So maybe short question, short answer, and of course, Kim, Alicia, you can jump in. How do you typically deal with imaging for monitoring of patients with metastatic castration-sensitive disease? Do you do it? How often?
So keep it short. I do PSMA PET when patients come to me already with that, and I go on the CT portion of the PET to assess volume by conventional, on the CT at least. And I use PET to identify patients for lutetium-based or PSMA-based radioligand therapy. I do monitoring advanced disease for the vast majority with conventional scans. The exception to that rule is if I have oligometastatic patients, I address those in a different manner, and I use PET as part of my decision process.
Alicia, Kim.
Sure. For hormone-sensitive metastatic disease, sometimes it looks like an oligometastatic patient, I will also use PET to understand if I need to do metastasis-directed therapy, and we have a little bit of an intensified strategy for that patient population, but generally it's somewhere between 6 and 12 months. Follow-up, whether or not they're having rising PSA, and that is with conventional imaging, CTs with contrast, and potentially bone scan, though that's less exciting.
Kim, only for hormone-sensitive disease, you know?
Yeah, similar in terms of PET scan, but I think I do tend to do more scans on a regular basis, conventional. Even if there's not PSA progression, I'm impressed by there's data that shows radiographic progression can occur before PSA progression. So I tend to do scans every 6 months, just out of curiosity, I have to say.
All right. I'm sorry, I cannot take all questions. Let's move to questions for these gentlemen and lady. Which of the following is not an FDA approved PARP inhibitor?
She's going to win.
I've lost so many times. You don't understand. So I'm really trying
Good.
You will
hard.
make it.
Go
When
for
that's
it.
not approved is talazoparib and abiraterone.
I think you're right. All right.
Amazing.
Uh-huh.
Good job.
It's a softball.
Guys, please wake up. Difficult one.
Oh, wow.
Name the PARP inhibitor.
How about it, guys?
Elaborate,
That's for
elaborate,
you.
tell us
That's for you.
recovery.
I feel that she's on the spot now.
Yeah.
Good luck.
Professor
You know what?
Chi.
I'm already negative 200, so I don't really care.
I love it.
I have no idea, but I'm going to guess. I'm going to just randomly guess rucaparib.
I don't think so.
No.
Anyone
you
else
wanna
want
go?
to try?
You want me
No,
to
I'm
go?
going to pass
No,
on that one.
Pass.
I
Pedro?
I'll see an N on the structure, so I'll say niraparib.
Wow, you're lucky. Well done.
Is that true?
Yes.
Good. Well, I should do this first. Yeah.
Yeah, well, you should have
Yeah,
do
forgot
that
to buzz.
before. But anyway, we give you a point.
Congratulations.
Well done.
It doesn't stand for niraparib. You know that.
I'm not sure I know.
I'm just teasing.
And now Professor Kimchi should
turn.
explain us
All
about the chemistry of PARP inhibitors.
You're feeling the
Kim,
pressure
please.
now.
Kareem, you're the one who chooses these questions. That was a mean one.
Not all of them. Okay.
Continuing down the disease spectrum, I'm going to be focusing on PARP inhibitors and metastatic castration-resistant prostate cancer and the evolution that's occurred. So really the treatment disease paradigm for prostate cancer really was revolutionized with the introduction of single-agent PARP inhibitors into our armamentarium for patients that were pre-treated metastatic CRPC that had HRR gene mutations, particularly BRCA2. This was about 4 or 5 years ago, really revolutionized what we do. We went from treating all patients to actually doing genome biomarker selected treatment for patients. Over the last 1 to 2 years, this has evolved with the introduction of 3 PARP inhibitors into the PARP inhibitor combined with ARPI space, olaparib with abiraterone, niraparib plus abiraterone, and talazoparib plus enzalutamide. However, this has not been as straightforward with the single agent data, and it's been not without some controversy, commentary, and debate that's been going on. And this has been owing to the differences in the trial designs, but as well because of the different regulatory approvals that have occurred across the world, actually. The approvals in the States have not been the same as in Canada and have not been the same as in Europe. Other than there is an empiric rationale, of course, for bringing PARP inhibitors from that late stage, pre-treated MCRBC into the first-line setting. Just empiric, if you bring it earlier in the disease, when patients are healthier, disease burden is less, it's most likely to work better. But there's also a biologic rationale. And this comes from preclinical data that shows interdependencies between AR signaling and PARP-mediated repair pathways, and thus brings up the hypothesis that by co-targeting both PARP as well as AR could result in increased efficacy both in HRR mutated prostate cancers, but also HRR wild type. And so we see these 3 trials that have read out and led to the approvals: Magnitude for niraparib, Propel for olaparib, and TALOPRO-2 for talazoparib. And it's very tempting to just lump them together because there's a lot of similarities. First, they're testing first-line combinations with ARPI and patients with mCRPC, looking for a radiographic progression-free survival for the primary endpoint. But I have to say here, though, the trials are actually diverging. Their study designs are different, the qualifying genes are different, and as you see, there will be some different results. And so I think we have to be very cautious about lumping these trials together and doing those cross-trial comparisons, and I'll go into some of those details. Starting first with the Magnitude trial, which looked at niraparib plus abiraterone, patients were pre-screened for their biomarker status and then subsequently put into 2 cohorts: biomarker positive with HRR mutations and biomarker negative, meaning no HRR mutations identified, and then randomized to either niraparib plus abiraterone or placebo plus abiraterone. Primary endpoint was radiographic progression-free survival, which was first looked at in the BRCA population, next looked at in the HRR population. The biomarker negative population, there was a futility analysis, and futility was met, so it never fully accrued. So the trial was positive. In the HRR patients, there was an improved radiographic progression-free survival, but this was really driven by the BRCA patients. Hazard ratio 0.55, so basically a doubling in the radiographic progression-free survival. But what I also want to point out importantly is that placebo arm. So these are the BRCA patients, and their radiographic progression-free survival was only about 10 months. This is very consistent across all the trials. And why is that important? Because this is about half as good as we think abiraterone or enzalutamide should do. This confirms these patients have poor prognosis and do very badly. We had previously published, 7 or 8 years ago now, that patients with BRCA2 in particular do badly and can have primary resistance upfront to abiraterone and enzalutamide. So important to identify these patients. We subsequently looked at the final analysis, reported this at ESMO just last year, and there was no difference on the primary analysis. However, it was apparent that there was differences in the baseline population. There was more poor prognosis patients in the niraparib side. And our pre-planned multivariate analysis, the hazard ratio was 0.66 with a nominal p-value of 0.02, again supporting that overall survival improvement with niraparib in patients with BRCA alterations as first-line therapy. There's also benefits in other clinically or patient-relevant endpoints such as symptomatic progression and time to cytotoxic chemotherapy. And this is, again, similar to all the trials. I'm not going to go into that sort of quality of life and other secondary outcomes in the other trials. We're going to do more top line. Next to the Propel trial, very different study design. In this study design, they took all comers and then randomized olaparib, abiraterone versus placebo plus abiraterone. Primary endpoint was radiographic progression-free survival. Positive study, improved radiographic progression-free survival in all comers, wild type as well as HR mutated. And there was also a trend for an overall survival benefit, but again, not statistically significant. But if you drill down into the data a little more, the benefit really seemed to be more so in patients that had HRR mutations. So you see a better hazard ratios, radiographic progression 0.45, more splitting in the overall survival. And then it looks really driven if you drill down right to the BRCA population. Again, the poorest prognosis patients, radiographic progression-free survival and overall survival hazard ratios of 0.2, pretty major benefit. However, the criticism of this is that this was a retrospective analysis, right? It came out all comers, and then you're dealing down in a retrospective analysis. And interestingly, FDA approved olaparib plus abiraterone only for the BRCA population, although in other jurisdictions, it's approved for all comers. Moving on to TALOPRO-2, this is talazoparib plus enzalutamide. Again, another different study design. And this does affect how the results come out and how we interpret these trials. They did actually do prospective analysis for HRR mutations, And then they stratified the patients and then randomized. So a little bit different than magnitude, which is a cohort followed by randomization. This is a stratification. Nevertheless, a little bit more robust than the PROPEL study, which looked at it retrospectively. Patients received talazoparib plus enzalutamide. And the reason that we're seeing abiraterone with olaparib and niraparib because of drug-drug interactions. There is drug-drug interactions between talazoparib and enzalutamide. However, the dosing was adjusted for that in terms of the talazoparib. Nevertheless, it's a different ARPI partner. So we have talazoparib, enzalutamide versus placebo plus enzalutamide. Again, it's positive in the all-comers, but what I'm showing here is the HR deficient population, again showing that benefit, more so in this HR population, hazard ratio 0.45, very similar to the PROPEL study for that total HRR population. And then we're also seeing some overall survival advantages here too as well. Again, a trend, hazard ratio 0.69, p-value 0.07. So pulling it all together, very different studies, different results, but we can actually make the same conclusions based on the data that's coming from all three trials, and they're all basically consistent. And the way I think about it is I don't think about the trials. I think about the patient that comes before me. I do the genetic testing. I get a result. What am I going to do with it? Well, if it's a BRCA1 or 2, there's unequivocal benefit. These patients do poorly. And so we really should be treating these patients first line. We need to identify them. And as you can see across the board, we see radiographic progression-free survival benefit as well as overall survival benefit. But on that latter point, I do want to point out another major difference between the trials, and that is crossover, or not crossover. None of the trials had crossover, but subsequent treatment, because that really does affect overall survival. In the magnitude study, 34% of patients at progression crossed over to receive a PARP inhibitor, and another 10% received a platinum agent, which we also know is very active in patients with BRCA. While in PROPEL and TALOPRO-2, it was actually a very small number of patients that actually crossed over. Nevertheless, we know that these patients can have primary resistance and frequently die very quickly, and therefore I think there really is a need to really bring these agents earlier in the disease. On the opposite end of the spectrum, you get the report back and there's no HRR mutation identified. And again, I still think the data is pretty consistent, which shows basically RPFS. So the non-HRR patients, basically there's less benefit. Even if you look at the absolute radiographic progression-free survival benefit, even though there's a hazard ratio that's trending towards benefit for non-HR mutations, the absolute benefit is measured in months, and there was no overall survival benefit in patients with non-HR mutations. Now, it gets a little more complex when we go to the HR mutated non-BRCA. And here we have a long list of genes. There's a lot of genes that have been associated with homologous recombination repair. However, some of these are more intimately related with homologous recombination repair defects than others. Some are just signaling DNA repair damage. Others are more involved with the repair. And therefore, their variability in terms of sensitivity to PARP inhibitors or their association with sensitivity to PARP inhibitors is also variable. And so there have been gene-by-gene analysis through these trials. This is from Magnitude. And what becomes very clear is that there are some alterations that really benefit from PARP inhibitors, and there's some that don't at all, other than BRCA2. And here's the data from TALOPRO-2. And you can see, for example, ATM, CHEK2, no benefit. And this is pretty consistent across the trials. But some of these others, like PALB2, there seems to be some benefit. There seems to be a lot of benefit, and probably because it's more closely related to BRCA and in terms of its functioning. So although we lump them all together, and altogether from the TALOPRO study, the hazard ratio is 0.68 with an overall survival trend, hazard ratio 0.065 for overall survival, I think we can use this data and as it matures and as we pull it across from other trials to really even get more precise with our treatment. And why is that? Because these treatments do have toxicities. They have financial toxicity, but they also have adverse events for patients. That includes myelosuppression, nausea, fatigue. There's a potential increase in pulmonary embolism, as well as long-term side effects. For example, we're already seeing some AML and MDS, and these are exposure-related side effects or from prolonged treatment with olaparib that can emerge over time. So we do need to be aware of this, and we need to be as precise with our treatments as possible. The landscape is evolving even further. We're seeing these combinations move earlier in the disease. The Amplitude study and the TALOPRO-3 study are looking at niraparib and talazoparib respectively in metastatic castration-sensitive prostate cancer. These trials have fully accrued, and we expect results in the next 1, maybe 2 years, so we could see another evolution and change of this. And then it's not in here, but there's also the EVO-PAR-1 study, which has also just recently started, and is looking at the ceraparib, which is a PARP1 selective inhibitor. It may have benefits in terms of less toxicity, especially less hematologic toxicity, and that's being evaluated in patients both with and without HRR mutations. Now, to realize the benefit of PARP inhibitors, we got to test. The guidelines have all come out across all jurisdictions that we should be testing all patients with advanced prostate cancer, regardless of family history. And these are some more specific details, but we really need to do this. It occurs in HRR mutations occur in 20 to 25% of patients, and they're out there. Personally, in my clinic, everybody gets a germline, everybody gets somatic testing, and we can talk about how that's done and how we do it and the ins and outs of tissue testing, ctDNA testing, as well as germline testing. But really, it really rests on that, not just for the treatment, but hereditary cancer considerations. Half these alterations are also germline, as well as I mentioned, prognostic. We can really identify the patients that are going to do poorly, and we can intensify their therapy. So thanks very much, and look forward to the questions.
Thank you very much, Kim. Very nice. And we do have questions, actually. I take the first one. What's the best test to identify candidates for PARP inhibitor, based on what you said? Does it matter whether alterations are homozygous or not?
What's the best test? The best test that gives you a result. So they all have their pros and cons. So tissue testing is the gold standard. However, we know that it can fail in about 30 to 40% of patients. And by failing, I mean there's insufficient cellularity, or the DNA is too degraded to yield a result. So that can happen. So if you get a test back and it's a failed test, then you need to figure out the next step. Germline testing will identify about half the alterations. Especially BRCA2, about half of them are somatic, half of them are germline. So you're going to find half of those. But you won't, if you've failed tissue testing, you have a germline that's negative, there's still a portion of patients that you want to identify. And then we need to move to, this is my order of doing things, I move to ctDNA testing. The problem with ctDNA testing is that it's very much dependent on tumor burden. If you have a low ctDNA fraction, you cannot detect the alterations. You need a ctDNA fraction above 1% to detect mutations, and above probably 20 or 30% to detect deletions. So you need a lot of ctDNA. In the first-line MCRPC setting, about 40% of patients will have too low of a ctDNA to detect alterations. So they all have their pros and cons. The benefit of ctDNA, if your ctDNA is too low to detect an alteration, that's a very good prognosis. So in a sense, you could probably wait, do something else, test again later when the disease is progressing again, to again see if you can detect an alteration. So that's the order I do it. As I mentioned, I do tumor testing, germline testing, all patients, and then move to ctDNA if I don't have a result.
Kim, maybe a question about mitigation of side effects. Do you do something different if it's a combo of a PARP inhibitor and an AR pathway inhibitor versus what you would do for PARP inhibitor monotherapy?
Do I do something different? No, I don't do anything different.
Yes. Yeah. All right. Management.
You know, the side effects usually occur early, within the first month, especially the anemia within the first 1 to 3 months. And although you see a lot of transfusions, once you get the dose settled for that particular patient after a few months, it's really not a problem. I've had patients on for 2-3 years on combination therapy or on PARP inhibitors, and very well tolerated once you get it. It's that first few months, though, that you do need to watch the patients. They can have sudden drops in their hemoglobin.
So the next question is actually a broader one, and I love to hear your three opinions. It's initially about PARP inhibitor or AR-PARP inhibitor combination, but it's more, do you think we can maybe drop the androgen deprivation therapy in mCRPC in the future because we're using some other drugs? What do you guys think?
So I think, as we talked about a little bit in the enzalutamide monotherapy setting, if we do that, we may find ourselves with some unforeseen consequences that we might be able to anticipate. If you're using an AR antagonist without using a GnRH agonist or GnRH antagonist, you will eventually potentially stimulate actually an increased production of testosterone, because you've got an antagonist on the receptor, so that of course causes feedback loops, so testosterone goes up. Yes, you're blocking it, but when it goes up, there's more peripheral aromatization to estrogens. You will probably get gynecomastia and other potential complications. So we just have to recognize that, yes, it's possible, but we may have unforeseen consequences. We also may have lesser disease control efficacy. Again, getting back to EMBARK, we saw that the combination of the two drugs was stronger in terms of disease control efficacy outcomes when compared to the single agent AR antagonist. So is it possible? Yes. Is there an opportunity for patients to sort of choose the side effects that they're willing to have, almost like a menu? Yes, potentially. I think that there are a lot of strategies, especially when we're thinking about limiting the duration of treatment and trying to cure patients to get them off all therapies, where we can use the opportunity to get rid of these drugs. But I'm not sure how that's going to go. And looking at all of the priorities that we have in terms of controlling disease, I don't know if that in the CRPC setting is necessarily where I would see us pulling back from our GnRH agonist or antagonist. But I'd love to hear others.
Please, short.
Yeah, just to add really quick, I completely agree. I'm not sure it's the right setting. I think we're going to find out more in the metastatic hormone sensitive studies like Liberty and other, where you're actually going after the good. It appears that one of the good early predictors might be PSA undetectable at 6, 7, 8 months, and so there's a study out there where actually you withdraw the ADT, and in this case is with apalutamide, but there are other efforts like that as like an adaptive approach. So I do believe in that setting we're probably going to think about. But just to go back to the basics, I mean, I remember when we changed the designation from castration-independent disease to castration-resistant disease, understanding that the AR pathway is still relevant. So unless we have level 1 data showing us that, skipping the castration is a good idea, I probably would not recommend that today.
The only reason to do it in mCRPC might be an economic one, because by the time they're CRPC, they've been on ADT for a few years, and if you stop it, they're probably not going to recover their testosterone. And then you can just monitor the testosterone, right? And you can just monitor every 3. Even if it starts to go up, it's going to take it a long time for it to go up. So if there's an economic reason to stop it, then you could stop it.
But not for your testosterone.
You have to monitor.
All right. Okay. You need to answer that one. What is the half-life of lutetium? 2 days. Okay.
6.7 days.
Wow.
Is it right?
Yeah. I think you're very right. It's about a week. Yes. Great. Okay. Guys, you're in trouble, I'm afraid.
Good job.
Okay. Try again. Among the following side effects, which one is not usually observed with radium?
Dry mouth.
I think dry mouth is not seen with radium typically. No, you're fine. No, it's a good answer.
That's correct.
Yes.
So, Green, give her points, please.
Make sure you give her points.
All right.
I knew adding the bot was going to help.
No, dry mouth is indeed a side effect of lutetium PSMA, not radium-223.
Right.
Very well done. All right. And, well, it's my turn to work now and speak about radioligand therapy for a couple of minutes. So, yes, use this one. So let's start with radium, by the way. We have radium on the market for about a decade now, thanks to a phase 3 trial called ACCME, which first demonstrated overall survival benefit for this agent in patients who either had failed docetaxel chemotherapy or were considered unfit for chemotherapy with docetaxel, obviously patients with mCRPC. And you see the Kaplan-Meier curves here on the screen. So one of the beauty with radium is that it's usually well tolerated, and we can use it even in frail patients, in the elderly. And at this time, we had really docetaxel only. This was quite prior the eve of the ER pathway inhibitors. So we were really happy to have something to propose also to patients who are not candidate for docetaxel chemotherapy. There has been, minimal phase 3 data since then with radium. One was unfortunately negative with a combination of abiraterone and radium-223, simply because this is associated with an excess in fractures, so please don't do it in your practice. But there were also some reassuring data with radium when used after external beam radiation therapy, and also some indirect suggestion that there might be a synergy when using enzalutamide together with radium. But again, this is retrospective analysis, not randomized. We need to be cautious about it. It's really hypothesis generating. But this hypothesis is being tested right now in the PEACE-3 phase 3 trial, which focuses on patients with metastatic castration-resistant disease, obviously bone metastasis, asymptomatic or mildly symptomatic. These patients have to have at least now a burn-protecting agent, denosumab or zolinic acid, and they are randomized on a 1-to-1 fashion to receive enzalutamide alone or combined with radium-223 for up to 6 cycles. We're waiting for the data of this phase 3 trial. This should come very, very soon. But during the course of the trial, actually the investigators analyzed what happened in terms of risk of fractures according to whether patients were on denosumab/zolinic acid or not. And I think this is very important for the current practice. You will see the blue curve, which is that of cumulative incidence of fractures if a patient receives enzalutamide and radium without a burn-protecting agent. Disaster. Really, up to 50% of these men develop at least one fracture by 2 years' time. Now, if you're looking at the green curve now, this is enzalutamide alone without a burn-protecting agent. It's not that good. About 25% of patients develop at least one fracture by 2 years' time. Now, if you look down at the bottom of this figure, the red and the black curves, those are the exact same treatments, but with a bone-protecting agent. And as you can see, the fracture incidence goes down to almost zero, which I think is, again, practically speaking, a very important message to all of us. Even when we're using an ER pathway inhibitor alone, such as enzalutamide here, we should use a bone-protecting agent, okay? Please send your patient to the dentist, do your homework as doctors, but treat your patient. I think this is truly important, and probably we forgot this too much in the last decade after we demonstrated the efficacy of zolinic acid and that of denosumab. Regarding the efficacy data from PEACE-3, I think we should have them quite soon, hopefully after the summer. Now let's move to PSMA-based radioligand therapy. And you're probably familiar with lutetium PSMA, first developed in the VISION phase 3 trial in very advanced stages. Then we had PSMA-4, first reported at ESMO, today again at the oral session. We're waiting for data from SPLASH and from ECLIPSE. And in earlier stages, lutetium PSMA is also being tested randomly, for example, in the PSMA addition phase 3 trial for metastatic castration-sensitive disease. The accrual is completed, patients are under follow-up, and even in earlier stages with PSMA-DC, for example.
So more and more we will learn about radioligand therapy targeting PSMA. How long should we use it? Is that really 4 to 6 cycles? Should we stop in case of a profound response based on PSMA PET, which I suspect we should, etc., etc. We're learning more and more. And regarding the mechanism of action, indeed, most cancer cells, prostate cancer cells, express PSMA, which is a protein, a transmembrane protein, and a ligand can be combined with lutetium or actually another radioisotope, so that the ligand will bind to the protein and the radioisotope will irradiate the cells and hopefully kill it. So it's really a Troy horse kind of treatment. So those are data from Vision as the first phase 3 trials. I just said it. Overall survival was improved, and RPFS was improved, I guess quite dramatically for both 60% reduction in terms of the risk of radiographic progression for survival and 40% reduction in the risk of death, which I think is not bad in such advanced setting where we were desperate finding new treatments. Actually, quality of life was also quite dramatically improved in this trial favoring lutetium PSMA, and time to skeletal events, which is associated with terrible morbidity, was also significantly improved, as was time to deterioration in pain, in severe pain. We're really serving all the patients, I think, with this treatment in this situation. Now, as I just said, PSMA-4 was the second randomized phase 3 trial, randomly assessing lutetium PSMA, this time in patients who have not seen docetaxel chemotherapy or any chemotherapy for CRPC. They were selected as mCRPC men who had failed one AR pathway inhibitor, and they were randomized to receive lutetium PSMA up to 6 cycles versus a switch to the second AR pathway inhibitor. Most patients actually had received abiraterone first, so they were switched to receive enzalutamide. RPFS was the radiographic progression-free survival was the primary endpoint of the trial. It was clearly met with approximately a 60% reduction in the risk of radiographic progression or death, as you can see. Medians approximately 6 months in the control arm, which was actually longer than expected, and approximately a year in the experimental arm, so we are basically doubling median time to radiographic progression with this treatment. So this is the third interim analysis for overall survival that we just presented today. And it was important, to show more for registrational purposes because, the FDA want to make sure, of course, that we're not harming patients in the long term with an experimental treatment. So they want to make sure that either overall survival is improved, which is obviously very difficult here given that 80% of patients from the control arm receive lutetium PSMA crossover, if you will. But they want to make sure that actually the experimental arm is not deleterious in terms of overall survival. So that's reassuring, at least to the FDA, I guess, to see that the hazard ratio is now below 1, and there will be a final analysis of overall survival. I honestly don't expect a better overall survival again because we were really comparing lutetium PSMA today versus in 6 months' time. So it's really hard to show OS benefit in such a situation. But what I think is more important here is that we're really serving patients in terms of quality of life or time to deterioration in quality of life. We show that in terms of FACT-P assessments, but also EQ 5D5L assessment. As you can see, it's approximately 40% reduction in the risk of quality of life deterioration, which I think is clinically relevant, at least to me. The same was demonstrated in terms of time to deterioration in pain. Basically, whatever the way we assessed it, either pain intensity, pain interference to normal life, and also time to disease-related pain, so focusing on cancer, if you will, related pain. And as you can see, the curves are very similar, whatever the way we are measuring this benefit. So if I'm trying to show a global picture of lutetium PSMA, it's overall quite well-tolerated treatment. You have to tell your patients about the dry mouth. The salivary gland cells do express PSMA, unfortunately, and we are irradiating them, but honestly not a really bad way. Most of my patients are really telling me, yes, I do have a dry mouth, but yes, I don't care that much. I can still enjoy my favorite French wine, which is truly important in my country.
Here too.
Good. Well, actually, U.S. wine is good too, I have to say. Anyway, myelosuppression is also something you need to pay attention, especially if you're treating patients with, quite important burden of bone disease. Be careful with this, man. It's really a balance between benefit and toxicity. GI effects are usually mild. You can prevent them quite efficiently. Nausea, vomiting, that's usually not a main issue. Fatigue is probably a true findings. Radioactivity to others is not a big issue, and back pain, bone pain is really cancer related, to be honest. So, as always, we are trying, as I said before, to use all our active treatments earlier in the course of a disease. With AR pathway inhibitor, Pedro showed us that this is a win. Coming from just 2 to 3 months of overall survival benefit, it's more years of benefit when used earlier in the course of a disease. Let's see what we will see with lutetium PSMA treatment. We have, as I said, PSMA addition completed, PSMA-DC ongoing in oligometastatic disease. So I think these trials will be important to look after. Also, don't pay too much attention to the slides too complex, but it's really to show you that PSMA is obviously a relevant target in general, regardless of whether we are targeting it with lutetium or maybe with something else. There are other radioisotopes, including obviously alpha emitters, potentially more potent, but also potentially more toxic. So we'll see where they can fit. But also, we might have some ADC targeting PSMA. We might have bispecific. We might have CAR T cells. And all this is under development. So stay tuned. There might be smart strategy to combine, to sequence, to maybe replace one with another one with less toxicity or more efficacy. Again, we know that this is an important target. All right. More questions maybe from you guys. Let's see. Thank you. Thank you so much. With lutetium PSMA, do you ever see PSA elevation while on treatment that are not related to progressive disease? Answer is yes, it happens. Probably rarer as compared to what we see with chemotherapy, for example, where it's quite frequent, 20% of the cases, probably, but it happens. So be careful with that. You need to confirm your cancer progression. And at the end of the day, PSA is one thing, but really clinical progression / imaging-based progression is probably more relevant clinically. Okay, so pay attention to the three aspects. Any agreement, disagreement?
I would agree. I think it's really interesting. There's increasing data to help us understand how to interpret a SPECT scan or a PSMA PET scan several cycles in. And as we're seeing increased heterogeneity in bone, for example, with maybe increasing lesions, this could be a true increase. So we have to work with our nuclear medicine colleagues and use imaging in addition to PSA to figure it out. But this is an area actively in flux that I think we've got a lot of information coming soon.
Next question is about any long-term adverse events using this treatment, like renal issues, renal compromise. So yes, we need to pay attention to that. The drug is being treated by the kidneys, and indeed, if you, and actually in terms of how should I say that, what the ideal dose we should use to avoid renal toxicity is not that easy to bet on. And I'm saying that because historically, we know what the dose is toxic to the kidneys when using external beam radiation, but it's difficult to extrapolate this dose to a radioligand. So we need to be cautious on that, and this is why before using more cycles, higher doses, we will need to do this in a context of a trial and indeed do measure what we're doing. And this will be important in the retreatment strategies, which are appealing, obviously. This will be even probably more important when using these drugs earlier in the course of the disease. Any comment?
Perfect.
All right, okay. How do you think about treatment sequencing for the metastatic setting? What kind of sequencing? I don't know who asked the question or if you want to comment. Is that sequencing of, in general? Maybe a general comment about sequencing.
Yeah, sure. I can. I'll take that one. I think it really depends on the patient and their situation. That's how I judge it. And then as well, I build in the genomics because we're testing large panels on all our patients. We know even though we may not be able to action some of those genomic alterations, they're actually informative. So if somebody shows up with, double, triple hit disease, meaning TP53, RB1, others, they tend to have a very poor prognosis. So I will get more aggressive with patients that have more aggressive phenotypes, genotypes, and I will be less aggressive with patients that have good prognosis disease. I think ARPI switch is a good example of that. So I know we've gone back and forth on the ARPI switch, but I think PSMA-4 is a good example of if patients are selected that have selected not to need chemotherapy, they had a 6-month radiographic progression-free survival. So it may be reasonable in a selected group of patients to do that, very selected. But on the other hand, if I have a patient with very aggressive disease, I'm going to treat them with chemotherapy. So I think it really depends on those patient and disease factors.
All right. For the sake of time, I won't be able to take the other questions. I'm sorry for that. So let's move to probably the last questions to these 3 colleagues. So
go ahead.
Where in Chicago would you find this? Is that Grant Park, Lincoln Park, Millennium Park, or Hyde Park?
Oh,
Do you want?
you already won, so it's okay.
I lived in Chicago too, so it's not really a
that's
fair
right.
question.
For you,
That's
yeah,
true.
that's right.
That's
I was gonna say Millennium.
Good
Yes.
answer.
Good job.
Very good job. So the last answer is a good one.
Beam.
So
Good job.
very nice. Yes, it's actually next door.
Yeah.
Just you can walk to Millennium Park. All right. We still have a little time for discussion. We're running late. Maybe about something about cardio-oncology. We didn't speak that much about it. I said something about burn-protecting agents, but let's speak about cardio-oncology. Alicia, you're really one of our specialists for those things. So any recommendation, how important it is, some tips for you for practice?
Sure. I think so. Cardiac complications are the leading second cause of malignancy in prostate cancer patients, and actually in many prostate cancer populations, they're actually the leading cause of mortality. So as we're trying to be clinicians to take care of our patients, it's either going to be heart disease or prostate cancer for many of them that will ultimately cause their demise. And there are multiple reversible cardiovascular risk factors that we can support our patients in engaging to correct, whether they are working with their primary care doctors or with their cardiologists. I don't think many urologists and medical oncologists are routinely checking cholesterol, checking hemoglobin A1C for blood sugar control, but we can encourage our patients to do this, and we can communicate with primary care and with cardiologists, and I certainly do. And when it comes to the ARPIs, multiple drugs can actually increase blood pressure, even when they're being used in a routine fashion. And so I always also work with my patients to make sure that their blood pressure is controlled, which is another reversible cardiovascular risk factor. So diet, exercise, cigarette smoking cessation, others, but these are things that we can work with them to work on. And it is our responsibility because this is the main competing cause of mortality for our patients.
All right. Any comment from you guys?
in your practice? Pretty much the same thing.
Perfect. Yeah.
Okay.
Not everybody has cardio-oncologists around. So I think, working with the primary care doctors at times, and be aware exactly of the cardiovascular risk factors is super, super important. And also the other thing is recognizing, as in other things in oncology, actually it's good pressure. Sometimes the new therapies make us talk about things, right? And we see that so often, right? Genetic testing, it was good pressure from the PARP inhibitors, make us talk about it. In this case, I think, for example, Relugolix, we start the Garalex first, but Relugolix made us start talking a lot more about cardio-oncology. So I actually like to think that there's good pressure put by therapies that make us talk about important topics for patients.
All right. There are resources to provide your patients. Again, Alicia, you may comment on that.
Sure. ZERO is a co-sponsor, I think, or is supporting this particular presentation tonight. And again, this is an advocacy organization available to patients here in the U.S. They run supports around financial needs. They run support groups for patients and peer support. They also have opportunities to learn about the disease on the website. It's easy for anyone to engage. And this 360 program that is listed here is a way for patients to call in and sort of have a needs assessment with the program that can help them even be matched with things like transportation, financial aid, and those kinds of things, which can be really critically important to our patients. So zerocancer.org is the website, and they're a great resource, as are other groups that are listed here on the slide.
Thank you.
And by the way, the winner is Dr. Alicia Morgans. Yes. Hey, look at this.
Oh,
you have
dear.
my flag.
Oh, wow.
Okay.
Thank you.
Oh, now we're jealous.
It reads champion and conqueror. Wow.
Oh my goodness. I only had to play 3 times to finally win. I feel so accomplished.
That is amazing.
Thank you.
Yes,
Thank
I think
you.
you're going to applaud her.
Thank you, Kareem.
Thank you. And really, thank you to the three of you for playing that. So thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, ZERO Prostate Cancer. This activity has been supported by educational grants from Astellas and Pfizer Incorporated, Bayer Healthcare Pharmaceuticals Incorporated, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, which are both Johnson & Johnson companies, and Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/YWU860.